Good afternoon to everyone and welcome to my presentation. First of all, I'd like to thank the organizer of this seminar, Professor Luca Cantarini, and my chairman, Claudia Fabiani and Rolando Cimaz. Well, uveitis is defined by the inflammation of the uveal tract. Uveitis may be primary or secondary to other inflammatory conditions such as rheumatic diseases. The two major forms of uveitis in rheumatic diseases are anterior uveitis, also known as iridocyclitis, and posterior uveitis, also known as chorioretinitis. Uveitis is estimated to be responsible for about 10% of cases of blindness in the United States. Uveitis may be classified according to the anatomical location of inflammation, with anterior uveitis accounting for 50% to 19% of all cases. Non-infectious uveitis is the most common type of uveitis observed. Despite its relative rarity, uveitis accounts for approximately the same amount of visual morbidity as macular degeneration and diabetic retinopathy. However, these two latter diseases are considered by the public as major causes of visual loss. Patients with uveitis do need rheumatologists. In fact, several systemic diseases may be associated with uveitis, and so uveitis may be the only tip of the iceberg of underlying systemic diseases. The systemic diseases that commonly are associated with uveitis are ankylosing spondylitis, psoriatic arthritis, Behçet disease, and in children, juvenile idiopathic arthritis. However, uveitis may occur also in other inflammatory conditions such as inflammatory bowel diseases, Vogt-Koyanagi-Arada syndrome, sarcoidosis, and multiple sclerosis. In this regard, a recent multi-center retrospective study aimed at evaluating the prevalence of spondyloarthritis in patients with anterior uveitis has been performed. A total of 798 patients were enrolled. 59% of them were male, and 67% has HLA-B27 haplotype, whereas 47% were HLA-B27 negative. Of note, the diagnosis of axial SPA and peripheral SPA spondyloarthritis according to the ASAS criteria was found in 50% and 70% respectively of the patient. In HLA-B27 haplotype, there was a higher percentage of patients with the diagnosis of axial ASPA and peripheral ASPA than the patient in HLA-B27 negative group. The conclusion of this study showed that a large percentage of patients with clinically significant anterior uveitis had an undiagnosed SPA. Moreover, this percentage was higher if the HLA-B27 haplotype was positive. In this regard, recently a diagnostic algorithm which combines the presence of the symptoms of spondyloarthritis with the presence of HLA-B27 haplotype has been developed. When anterior uveitis is present, patient should be assessed also for typical symptoms of spondyloarthritis, including inflammatory back pain, sacroiliitis on X-ray or MRI, joint swelling, heel pain, a positive family history of spondyloarthritis, and personal history of psoriasis or inflammatory bowel disease, in order to disclose a diagnosis of spondyloarthritis. Uveitis is also a common manifestation of Behçet disease. As we can see in this picture, is described an analysis on 880 patients from eye clinic in Istanbul. The most common anatomical location of inflammation was bilateral in the majority of the patient, and the type of uveitis found in this course was panuveitis, equal in both sexes, followed by posterior uveitis. Moreover, the most common findings of uveitis found in posterior uveitis and panuveitis was vitritis and retinal vasculitis. Hypopyon, whereas hypopyon, once considered the hallmark of disease, characterized by the presence of exudate in the anterior chamber, was found only in a small percentage of patients, equal to 12%. Epidemiologic data are a useful and important tool for clinicians during the differential diagnosis of uveitis. Epidemiologic data depend on patient geographical region, increased migratory fluxes, anatomic pattern of uveitis, and finally by the etiology of uveitis. On this basis, we performed a epidemiologic study aimed at describing the epidemiologic profile of non-infectious uveitis in a cohort of 278 patients enrolled in from January 2026 to January 2016 in two tertiary referral rheumatic centers in Italy. Demographic, therapeutic, and clinical data, as well as ocular and laboratory findings with ophthalmologic examination, were collected during the observational period. Looking at the results, anterior uveitis was the most common pattern found in our court, followed by posterior uveitis and panuveitis. Uveitis was slightly higher in female than male, and the ocular involvement was bilateral in one half of the patients. With regard to course of uveitis, non-recurrent acute or chronic was found in anterior uveitis, and a chronic course was found in intermediate uveitis. A specific diagnosis was found in one half of patients. The remaining 135 patients were classified as idiopathic uveitis. Beige disease followed by ankylosing spondylitis and in children juvenile idiopathic arthritis were the most common systemic diagnoses found in our court. Moreover, the isolated HLA-B27 related uveitis and Fuchs heterochromics iridocyclitis were the most common type of uveitis found in the subgroup of non-idiopathic uveitis. In the group of anterior uveitis, a diagnosis was found in a systemic diagnosis was found in 54% of patients. The most common was ankylosing spondylitis, followed by juvenile idiopathic arthritis and Beige disease. In intermediate uveitis, the most common diagnosis was Beige disease, followed by ankylosing spondylitis in one patient. Both in posterior uveitis and in panuveitis, Beige disease was the most common diagnosis. In panuveitis, the most common diagnosis was ankylosing spondylitis. With regard to treatments, topical medication including either corticosteroids or non-steroids anti-inflammatory drugs were the most prescribed medication. Moreover, systemic corticosteroids combined with disease-modifying anti-rheumatic drugs were employed in 28% of the patient, whereas systemic corticosteroids were used alone in less than 26% of the patient. Anti-TNF agents alone was used in 21%, about 21% of the patient, while anti-TNF combined with disease-modifying anti-rheumatic drugs was used in less than 50% of the patient. The subgroup analysis among isolated systemic and idiopathic uveitis showed no statistical differences with regard to gender, whereas significant differences were found with regard anatomic pattern and disease course. In detail, idiopathic uveitis was found recurrent, more frequently recurrent with no predilection on laterality. Isolated uveitis was more frequently chronic and unilateral. Systemic uveitis was non-recurrent, acute or chronic, and often bilateral. Overall, the most common identified systemic disease were Beige disease, followed by ankylosing spondylitis and juvenile idiopathic arthritis. The most common anatomic pattern was anterior uveitis followed by posterior uveitis. Panuveitis was found in 60% of the patient, whereas intermediate uveitis was found in less than 6% of the patient. Summarizing, a close collaboration between rheumatologists and ophthalmologists is required for managing uveitis. A systemic disease should be considered when a patient presents with uveitis. Moreover, epidemiologic data are important and critical tool for helping physicians during differential diagnosis of uveitis. I thank you for your kind attention and wait for your question.